Dr. Bhattacharya, good morning. Good morning.
So
You are muted.
say good morning.
Yes. Good morning. Good morning. Okay. Good morning. As previous year, and with us today will be Dr. Avik Bhattacharya, who is a very senior radiology teacher. He was earlier at IPGMR, a senior radiologist at CMRI Kolkata. So Dr. Avik Bhattacharya will take us through the. So in exam, Dr. Pancha, they are often given a scenario, picture saying that out just point out the normal structures. So for DNB students, important, and then you show the abnormalities. So have a nice discussion on the what they see normally in different cuts,
Right.
and then rest part of your discussion. So you can share your screen and start. A lot of people will join.
All right. Thank you, sir. So can you hear me clearly?
Yes, yes. You're audible. Clear.
Your sounds were interrupting. That's why I thought.
Oh,
perfect.
okay.
So
now your sound is very clear.
Shall I start sharing my screen?
But you're not audible.
Yes, sir. Can anyone see my screen?
Yes, yes.
It is seen, no? Perfect.
Recording in progress.
So, good morning, everyone. As sir said, today our discussion, the aim of our discussion would be to characterize a focal liver lesion. Sir, am I audible?
Yes, yes, very clear.
All right. So, as we have many of our DNB students, I'll go through the basic segmental anatomy of liver to understand where exactly a lesion is situated inside liver, in which segment a liver is situated, a lesion is situated. Then we will try and figure out which modality we use to characterize a liver lesion if it is a focal liver lesion. And finally, our main goal of today's discussion would be to discuss the LIRADS classification system. This is very important, and being a radiologist, we follow it in our day-to-day practice. It is very simple, but to convey it to you, to make you understand the radiological parameters which govern the LIRADS classification is very important, because you see on your day-to-day practice many cases of focal liver lesion. You can characterize the lesions yourself. You need to know which modality you should use, what are the sequences you should use, and what are the interpretation you can make after seeing a focal liver lesion. So starting with the with the segmental anatomy of liver, we all know, and in our previous discussion also we have discussed the different segments of liver, and we know the different so can you see my cursor? I think cursor is not seen, but you can see my image. All right. So as we know that hepatic vein and portal vein differentiates different segments of liver. The right hepatic vein, middle hepatic vein, and left hepatic vein. Middle hepatic vein divides the liver into right and left lobe. The right hepatic vein divides the right lobe of liver into anterior segment and posterior segment. and left hepatic vein divides the left lobe of liver into medial segment and lateral segment. Similarly, at the level of portal confluence, when the main portal vein bifurcates into the right and left branch of portal vein, we take an arbitrary plane at that level, and we assume the segments which are superior to that level is the superior segments, and which are inferior to that level are the inferior segments. So in this picture, you can appreciate that in the right lobe, if the segment is situated anterior to the right hepatic vein and it is superior to the portal confluence, it is segment 8, and just below to it is segment 5. If the segment is posterior to the right hepatic vein, it is segment 7 if it is superior, and if it is inferior, it is segment 6. We have discussed these things and in our interactive classes also. Similarly, on the left side means anterior to the or anteromedial to the middle hepatic vein. The lesion which the liver segment which is above the portal confluence are segment 4A and 2, and below it is 4B and 3. So after the segmental anatomy on schematic diagram, if you see the images of a CT scan of liver, you can see in this particular picture, I cannot move my cursor. So here you can see the portal vein, the left branch of portal vein just anterior to the inferior vena cava. Can Mehul help me how to show the cursor on this PowerPoint? Any clue? Because I'm trying hard to get my cursor.
This is oh, so that he can.
Sir, without cursor, can you carry on?
We can see.
All right. So basically in this particular picture, we can see the middle hepatic vein, the right hepatic vein, and the left hepatic vein. The middle one is the middle hepatic vein, which is in the right side is right hepatic vein, and the left side is the left hepatic vein. And how it divides different segments of liver, as I have told you already. This is at the level superior to the portal confluence. Here you can only see the liver parenchyma. You cannot see the gallbladder, falciform ligament. So in this segment, which is superior to the portal confluence, these are the segments. The medialmost segment is the segment 2. Then the lateral segment of left lobe is segment 4A. Posterior to the middle hepatic vein, but anterior to the right hepatic vein is segment 8. And posterior to the right hepatic vein is segment 7. Similarly, if I go below the portal confluence, this is just below the portal confluence. This is the level where you can see the right and left portal vein separately. And here at this level, if you divide the liver similarly, then it would be like the medialmost segment inferiorly situated is segment 3. Then the segment which is abutting the gallbladder is segment 4B. On the right side, the segment abutting the gallbladder is segment 5. And posteriormost segment of posterior inferior segment of right lobe is segment 6. So this is the segmental anatomy of liver. Well, I may not need cursor for today's discussion, because today our main goal would be to characterize focal liver lesion, and all the lesions would be descriptive. They will speak themselves. Like when we see a lesion, a benign lesion in liver, how it look like, and when we see a suspicious lesion in liver, how they look like, we will discuss and we'll try to characterize. So to try and characterize different focal liver lesion, we need to know first which modality we should use. To screen a liver lesion in patient with liver cirrhosis, a patient with chronic hepatitis B infection, we frequently screen the liver to look for early HCC or early detection of any cancerous lesion in liver. In that scenario, the ultrasonography plays a very crucial role to pick up early lesion and to start therapy to make it cure. However, to characterize different liver lesions, ultrasonography is not that good modality because we don't have any enhancement characteristic to be seen on ultrasonography. Although we have ultrasonography contrast, which will show you the contrast enhancement, but more or less in our country, we rely on the triple phase or multiphasic CT scan or multiphasic MRI to describe a focal liver lesion. Because the main ball game in differentiating a liver lesion would be how the lesion is enhancing when it is enhancing after giving intravenous contrast. We'll be coming to that part later on. So we'll be discussing on which modality we should use. And I have told this is mostly triple phase MR or triple phase CT scan we use to characterize focal liver lesion. Then we will go through in a smaller, like just we'll touch the hepatocarcinogenesis. Hepatocarcinogenesis means how from a dysplastic, from a regenerative nodule to dysplastic nodule to early HCC or progressed HCC, how is the journey of a nodule in a cirrhotic liver or a nodule in chronic hepatitis B infection. Then what are the specific imaging findings of HCC, hepatocellular carcinoma, and the other lesions in liver which are malignant but not hepatocellular carcinoma. And ultimately we'll jot down into the different subsets of LIRADS classification, how we classify focal liver lesions. So mostly, if we talk about a focal liver lesion in a non-cirrhotic liver, then there are mostly benign lesions, which are cyst, hemangiomas, FNH or focal nodular hyperplasia, hepatocellular adenomas. They are also seen, they may be seen in a cirrhotic liver, LIRADS 1, LIRADS 2, even in LIRADS 3, we classify. However, they are much lesser in number. They are mostly seen in non-cirrhotic liver. And in non-cirrhotic liver, the malignant lesion we see is the metastasis. There may be hypervascular metastasis or hypovascular metastasis. And the malignant lesion we very frequently encounter in a cirrhotic liver or a liver with chronic hepatitis B infection are the hepatocellular carcinoma or intrahepatic cholangiocarcinoma. We may have a biphenotypic feature of a lesion. That means both HCC and ISCC. We may see metastasis from a known primary in a known patient with cirrhosis. However, they are much lesser in number. We have also categorized them in a separate category in our LIRADS classification. Well, coming to this finding, where you see a lesion in right lobe of liver is a big lesion. If you see very carefully, the margins of the lesion is very smooth. It is hypodense, means it is more black than the rest of the liver parenchyma, if you agree so. And it is a contrast study. That means we can see the contrast inside the aorta. There is no wall enhancement. There is no internal enhancement. And if you put a cursor at the midpoint of this lesion, you would see, you would measure the Hounsfield unit of that lesion would be the same of the Hounsfield unit of water. So if it is a water containing or fluid containing lesion inside the liver without any peripheral wall enhancement, then we should call this lesion to be a benign lesion. And what is the name of this lesion?
Cystic.
It is benign cyst, benign or simple hepatic cyst. And if I see this type of cysts, cysts in a liver parenchyma, which are multiple of varying sizes, few of the cysts may be of different densities. This is the typical picture where we see multiple cysts inside the liver of varying sizes. Few of them are hyperdense, means some of them are more attenuation value, more bright than the rest of the cysts, probably because of the internal hemorrhage or internal high protein content, or maybe due to internal infection. All depends on the different scenario, different, they will present in different clinical scenario. However, if I see this type of lesions, so we know we are dealing with a polycystic liver disease. Now, not all cysts are the simple cysts or the cyst with polycystic liver disease or polycystic kidney disease. Some of the cysts are infected cysts or infective cysts, and well-known cyst which is infective cyst in liver is hydatid cyst. Hydatid cyst has got 5 different WHO category. How we classify intrahepatic hydatid cyst. In this particular case, we could see there is a cyst. Cyst means it is a balloon. It's a fluid containing balloon inside the liver, as you can see here. In this picture, we could see a well-defined uniform wall. So usually simple cyst lacks a wall. However, the hydatid cyst would have a well-defined wall. But if you go through the WHO classification, you will see the CL variety, CE1, CE2 to CE5 variety, and all the different varieties of hydatid cyst would have different feature. CL variety would not have a perceptible wall, and in that particular variety, we cannot differentiate hydatid cyst from a simple cyst. However, from CE1 onward, when we see a wall, when we see a dependent debris, when we see internal daughter cysts, when we see a curvilinear undulating membrane inside, we could say with certainty that we are not dealing with a simple hepatic cyst. This is probably a hepatic hydatid cyst. In this picture, you could see a well-defined wall and independent debris. So this is a hydatid cyst. This is very characteristic of picture of hydatid cyst, showing a big cyst and multiple internal daughter cyst arranged at the periphery of the mother cyst. So this is typical CE2 variety of hepatic hydatid disease. And when it goes into a CE3 variety, we will see a detached curvilinear internal membranes. Here we punctured the cyst with a needle. We could see a straight linear echogenic lesion. Tip is bright, giving artifact. This is a needle. We hit the cyst and we aspirated the fluid. We injected sclerosant and re-aspirated. The procedure is called PAIR. And this is the follow-up scan showing much smaller in size of the hepatic hydatid cyst. Although we could see some curvilinear membrane still inside, but lesion becomes smaller. We followed it up. And this picture, sir, am I audible?
Yes.
I cannot show those lesions in the picture. Is it okay? Well understood. These pictures are Mehul, you okay with the picture?
Yes, sir. Yes, sir. Yes, sir.
All right. So this is a CE4 variety of hepatic hydatid cyst where you could see one daughter cyst inside, a black or anechoic cystic lesion within a heterogeneous mass-like structure. So when cyst, hepatic hydatid disease became inactive cyst or dying cyst, it become a inhomogeneous or heterogeneous soft tissue mass-like lesions that we call a CE4 stage of hepatic hydatid disease. And this is that. Eventually, that cyst ruptured into the biliary system and patient vomited membranes. This is, I have followed this patient particularly, so I know the evolutions of the patients. This is the final picture of hepatic hydatid. It's the same patient. This much smaller lesion. This is almost the peripheral calcification has started. So this is CE5 variety of CE5 stage of hepatic hydatid disease. So from CL to CE5, these are the normal evolution of the hepatic hydatid disease. Well, this is the CT scan of a different patient showing two large cysts inside liver having a curvilinear internal membrane. And this is also very characteristic picture of hepatic hydatid cyst. Another patient. Here, in this particular case, you could see two lesions. One lesion is situated in liver right lobe, you could see a hyperintense lesion in T2 weighted image. So all are MRI image on T2 weighted sequence, the fluid containing structures appear bright or white. Here in this liver, we could see a round lesion which is white. This hyperintense lesion is a cystic lesion. You could see the intensity curvilinear hypointensity is inside. So these are the membrane. So again, MR picture of a hepatic hydatidic disease. We could also see a fluid level inside. Hypointense black and white. There is a layering, and this is the dependent debris. Again, this feature is suggesting hepatic hydatidic disease. However, this patient is having a mass lesion also, could be seen in left lobe. You could see the left kidney. See the left kidney carefully. There is a mass lesion in left kidney with a heterogeneous thrombus inside the left renal vein and inferior vena cava, straight going up to the right atrium. So if you could see the IVC is much dilated than aorta, and IVC is filled with heterogeneous thrombus. So this is the renal cell carcinoma with renal vein thrombosis, inferior vena cava thrombosis. Both of them appear grossly dilated with heterogeneous thrombus inside, and this is going up to the right atrium. Again, this is my patient. Patient came with features of loss of appetite, loss of weight. We did MR. We see both the diseases simultaneously going inside his body. Well, so if I have started with the focal liver lesion, which are mostly cystic, we will finish off with this picture where we could see there are 4 pictures. The last picture is the post-procedure, post-catheter drainage picture, but for the first 3 pictures are non-contrast, arterial phase and portal venous phase of contrast study of CT scan. Here you could see the lesion is situated in left lobe of liver. You could appreciate a hypodense lesion, hypo-enhancing lesion in left lobe of liver, which is situated at the periphery with a breach in overlying cortex or overlying capsule of liver. So it has breached to the lesion has ruptured into the perihepatic space, and there is some perihepatic collection alongside the left lobe of liver. So if you see this type of picture where you see a lesion, a patient presented with fever and right upper quadrant pain, you see, or probably in this particular case, we will have a patient having epigastric pain because the lesion is situated in left lobe, which is rupturing and forming a perihepatic collection. So this is most likely a ruptured liver abscess into the perihepatic space. And we have drained both the liver abscess and the perihepatic collection uneventfully. Another picture, this is an MR picture of a lesion, a cystic lesion in liver. Why I have kept this? Because the left-hand side image is the T2 weighted image. In T2 weighted image, all cystic structures appear bright. Here, the lesion, 2 lesions, both of them are looking bright or more white than the rest of the liver parenchyma. So most likely this is cystic. But the right-hand images are the diffusion weighted image, where you could see the lesion is diffusion restricted. It is much brighter than the rest of the liver parenchyma. If a lesion inside our body is diffusion restricted, the differentials are very less in number. Here in this particular case, this is liver abscess. Abscess or any infective abscess is diffusion restricted. In some cases, tumors, because of their hypercellularity, they are diffusion restricted. And in brain, the infarct brain parenchyma is diffusion restricted. So diffusion plays a very important role in differentiating many pathologies inside our body. In liver, it differentiates a tumor versus an infective versus a benign, a malignant tumor, a benign tumor, and the infected lesion inside liver. So again, another picture where there is the upper picture is a CT scan picture showing a lesion, is a big lesion in the right lobe of liver. is a hypotenuse lesion. That means it is more black than the rest of the liver, although the very smaller amount of viable liver is visualized alongside the gallbladder. And within that hypotenuse or darker lesion, there is a bright spot. Actually, this patient had a history of road traffic accident with liver laceration and pseudoaneurysm formation. We did an angio. You can see the picture below left showing a pseudoaneurysm inside the hepatic parenchyma, and we embolized it. So those are a gamut of different types of liver lesions, which are all mostly benign. And to characterize them, we need either ultrasonography or CT scan or MRI. Now I'll be coming slowly to the actual LIRADS classification. Although the LIRADS classifications are applied or applicable to liver in patients with liver cirrhosis or chronic hepatitis B infection, and to characterize the different stages of or evolution of hepatocellular carcinoma or non-ACC malignant lesion in liver. So in this particular case, this is a non-cirrhotic liver. I'll start with this. And in this liver, there is a lesion. We can see it is breaching the homogeneity of the normal liver parenchyma. At the periphery, there is a lesion. On different phases of contrast study, you see the characteristic enhancement pattern. It started with the peripheral nodular or peripheral nodular enhancement of the lesion with central non-enhancing area. We did a sequential scan, and there is centripetal filling in of contrast. And on delayed images, the contrast is the lesion is homogeneously enhancing. And see, in all the sequences, the enhancement pattern of the lesion follows the enhancement pattern of the vascular structure inside the liver. If you see this type of lesion, sorry, you are very sure a lesion is enhancing peripheral nodular enhancement with centripetal filling in on delayed sequential post-contrast study. So this is a typical example of liver hemangioma. Again, the same type of lesion, hepatic hemangioma on MR, showing the centripetal filling in, the early arterial phase, portal venous phase, hepatic venous phase, and delayed images showing the peripheral enhancement of contrast, and slowly, gradually, it is filling the entire volume of the liver lesion. So this is the intrahepatic hemangioma. Now, this is the...
In hemangioma, Dr. Bhattacharya, in hemangioma, is there early washout also?
No,
is
sir.
there early washout?
No. In hemangioma, this is very characteristic feature of hemangioma that it will retain contrast inside. And in all sequences, if you compare the hemangioma enhancement with the hepatic vein or inferior vena cava, you will see the same, almost same attenuation pattern of the IC or hepatic vein and the hemangioma. So gradually, when the contrast will get excreted from the body, then it will be hypotenuse. The lesion will be hypotenuse. But till the contrast is there in the circulation, the hemangioma would be having the contrast inside. In some cases of sclerosing hemangiomas, where there are atypical hemangiomas, then it will not follow the normal contrast enhancement characteristics. Particularly when we see, as it is a very, very common liver lesion, sometimes we see this type of lesions in cirrhotic liver as well. And if they are sclerosing variety and not fitting with the normal contrast enhancement criteria of a normal hemangioma, then we are stuck actually. Then we call them is probably LR3 or LR4 lesion. We cannot differentiate those lesions from a suspicious lesion for HCC. That sclerosing variety of hemangioma would not have the typical contrast enhancement characteristic that is shown here. This patient is a middle-aged female having discomfort in upper abdomen, bulging upper abdomen at the epigastric region. We did a CT scan. On the non-contrast study, there was only a bulge, mild ill-defined hypodensity in the left lobe of liver with contour deformity When we do a contrast enhanced study, the lesion is homogeneously enhancing with a central scar. If I see this type of lesion, the diagnosis is, this is a spotter actually. You have to tell me the diagnosis saying this. And this is focal nodular hyperplasia. Another benign lesion in liver, which are associated with oral contraceptive pill. Sometimes it's very difficult to differentiate from a malignant lesion. However, we see these lesions in a non-cirrhotic liver. And sometimes patient present with severe pain because of the intratumoral bleed. This is the picture of a very characteristic large lesion in left lobe of liver with a substantial blood product like hyperdensity within, that means intralesional bleed, and this is hepatic adenoma. Okay, so you need not to break your head differentiating those lesions, because most of those lesions having a typical sets of clinical features, and these are very easily, you can differentiate cyst, simple cyst, hydrated cyst. Then if it is a solid lesion, either it is a benign lesion in non-cirrhotic liver, a hemangioma, it will follow a characteristic pattern of enhancement, then FNH and hepatic adenoma. Now the challenges to us are a lesion in a cirrhotic liver or a lesion in a patient with chronic hepatitis B infection. Here we follow the Lyra's classification, and I'll be just giving an overview of how we characterize the lesion in a cirrhotic patient or in a chronic hepatitis B virus infected patients in liver using different modalities, mostly the triple phase CT scan or triple phase MRI. So this is the MR picture of a typical cirrhotic liver. You could see there is volume redistribution. The left lobe and caudal lobe is enlarged. See the margin of liver, it is nodular or lobulated. Heterogeneity is there inside liver parenchyma, and you could see enlarged spleen also. So this is a patient with a cirrhosis, but we could not see any focal lesion here. All right. And this contrast enhancement phases I have discussed in repeated classes. I am not going to go in details of that different phases of post-contrast images we take after contrast triple phase CT or MR. But just a brief, we take early arterial phase. So when we start injecting contrast, we start counting time. Suppose we are going to give a 80 ml contrast, and it will take around 25 seconds, 20 to 25 seconds to go the entire amount of contrast inside the body. And then we give saline chase to utilize the contrast in a better way. So we have a machine. This is called pressure injector. And through this machine, everything is programmed. When we start injecting the contrast, we start counting the time. And from starting of contrast injection, in between 15 to 20 seconds, it is the early arterial phase. At that point in time, the contrast is still injecting. We are injecting because it will take another 5 to 10 seconds to finish up the entire volume of contrast to go inside the body. But we start scanning because after 15 to 20 seconds of starting of intravenous contrast, this is the early arterial phase where the contrast will stay inside the larger arteries, aorta and its branches. So these are important to have a roadmap of the vascular structures inside the abdomen, mesenteric vasculature and all, renal vasculature and aortic, proper aortic evaluation. After that comes the late arterial phase, where it comes at around like 25 to 30 seconds or probably 30 to 35 seconds. Around 30 seconds is late arterial phase, where we could see the enhancement of a hypervascular tumor. Suppose a neuroendocrine tumor in pancreas or early HCC in liver would enhance at this point in time, 25 to 30 seconds after starting of injection of contrast. So this is late arterial phase. Here the parenchymal tumors would enhance, which are hyper-enhancing tumors, would enhance in arterial phase. After that comes the hepatic, the portal venous phase. Actually, portal venous phase comes around 45 to 50 seconds, and then hepatic venous phase 60 to 90 seconds, and then delayed phase, depending on the situation, we fragment our delayed phase images. Like in hemangioma, we take 2 minutes, 5 minutes, or even 10 minutes study. After giving contrast in a MR study, we take many delayed images. Actually, we take a equilibrium phase image. It is taken after 1.5 hours. That means after 90 minutes of injecting the contrast. So there are different phases. You need to understand, because the entire ball game of enhancement of different liver lesions in cirrhotic liver depends on this, the different phases of contrast enhancement. So why we need this? Because if I characterize a hepatic lesion early, we can go for cure, either by hepatic resection or by ablation or by liver transplantation. If it is beyond the jurisdiction of our resection or ablation, we cannot cure it, then comes the palliation, where we either go for transarterial chemoembolization. Many novel drugs has come up to treat the hepatic tumors. So what is the actual hepatocarcinogenesis? What happens inside a hepatocellular carcinoma? Sir, can you remind me when I am done with the 1 hour time? Because
20 minutes more.
all right.
20 minutes more.
All right, sir. So when there is a early HCC or dysplastic nodule turning into hepatocellular carcinoma, at the molecular level, the fat accumulates inside the lesion, and it increases the vascularity. These 2 points are very important: the fat accumulation inside a liver lesion and the increasing the vascularity. Because in our different MR sequences, we will use these molecular features for the help of our diagnosis. What we do, if there is increased cellularity, there will be diffusion restriction. So the first 2 images are, first image is a T2 weighted image, where we could see a lesion in right lobe of liver, which is hyper enhancing. That means it is more bright than the rest of the liver. And the next picture is the diffusion weighted image, where it is much brighter than the rest of the liver. That means it is diffusion restricted. A lesion, if a liver lesion is diffusion restricted, it is hypercellular. That means it is going in favor of hepatocellular carcinoma. It is an ancillary feature of a Leiders classification. And then the last 2 pictures are in-phased and opposed-phased sequence. Again, a very important MR sequence we use in characterizing different liver lesions. And here, there is a significant signal drop of the lesion because the significant fat accumulation inside. So seeing this picture, I am very sure this lesion has got a significant amount of fat inside and hypercellular tumor. So these 2 pictures, these 2 cellular molecular level pathological changes or hepatocarcinogenesis, we are transforming that molecular changes into our imaging interpretation and telling this patient is having a lesion which is not a benign lesion. Most likely we are dealing with a hepatocellular carcinoma. And again, when a lesion becomes turning from the regenerative to dysplastic to early hepatocellular carcinoma, the portal venous supply reduces and unpaired hepatic arterial supply increases. So when the lesion will enhance, the rest of the liver, which is actually the portal venous supply, would not enhance. And when actually the rest of the liver will enhance because of the portal venous supply, the lesion would be hypoenhancing. That means in the arterial phase, the lesion would be brighter than the rest of the liver, and on portal venous phase, the lesion would be darker than the rest of the liver. So that unpaired hepatic arterial supply gave us this opportunity to differentiate a focal liver lesion from the rest of the cirrhotic liver using this multiphasic contrast study. So in this particular case, you could see on the early arterial phase, The lower row, the left-hand side image, is the peripheral irregular enhancement of the tumor. On late arterial phase, you could see the tumor is enhancing than the rest of the liver parenchyma. However, the last picture is the portal venous phase, where you could see the rest of the liver is more bright than the actual liver lesion. Can you appreciate, Mehul? Can you appreciate that enhancement on arterial phase and washout on portal venous phase?
The right upper picture.
Yeah, the lower column, lower line. Our right upper picture is the T2 weighted image, diffusion and in-phase opposite phase. But the lower section is the contrast enhancement pictures, where we could see the enhancement on arterial phase and washout on portal venous phase. So those are things we see in a patient, a cirrhotic patient having a focal liver lesion. Well, so just you need to remember these few points. 5 features of a hepatocellular carcinoma. They are a malignant liver lesion, which appears in a cirrhotic liver or chronic hepatitis B virus infected liver. These 5 features are the pillars to differentiate different liver lesions. One is the enhancement pattern of the tumor after giving contrast. Enhancement are of different types. One is called non-rim enhancement, one is rim enhancement. I'm not going into the details of that because it will be very confusing for you. The non-rim enhancement means it will be central enhancement. They are characteristic of the hepatocellular carcinoma. And the washout would be also the non-rim washout. The enhancing part would get washout on portal venous phase. Vis-a-vis, in an intrahepatic cholangiocarcinoma, we see peripheral rim enhancement, and the washout would be also a rim washout. The peripheral washout would be there. And then on delayed image, the hepatocellular carcinoma would have a well-defined peripheral enhancing capsule. The size of the tumor we see, if the lesion is less than 1 centimeter, then 1 to 2 centimeter, and then more than 2 centimeter, we characterize the lesion in different category. We see the enhancement characteristic in arterial phase, portal venous phase. We see the capsule. And taking all this in account, we formulate a classification system, which is called a Lyrath classification. Here, this is the Lyrath classification, where if we call a Lyrath 1 lesion, that means it is a definitely benign lesion. That means either it is a cyst or it is a hemangioma, very characteristic picture of hemangioma. Lyrath 2 is probably benign. That means it has got most of the characteristics of benign lesions. However, we are not sure. We have to follow this decision up. Lyrath 3 is intermediate. We are not sure. Lyrath 4 is probably malignant. Lyrath 5 is definitely HCC. Lyrath 4 is probably HCC. Lyrath 5 is definitely HCC. And one category is called Lyrath M, where this is definitely malignant. However, this is not looking like a hepatocellular carcinoma. It may be intrahepatic cholangiocarcinoma. It may be a hypervascular metastasis, something else, but this is malignant, not fitting with the characteristic of hepatocellular carcinoma. If I see a tumor thrombus or any soft tissue structure inside the vein, we call LRTIV. After treatment, we call LRCR. If we cannot characterize the lesion because of the image, poor image quality, we call LRNC. So it's a large gamut of different category, different its interpretation. I'm not going into that. I would just tell you a simple thing. I'll just show you this 2 picture of one is hepatocellular carcinoma, one is intrahepatic cholangiocarcinoma. These 2 lesions are most commonly encountered lesion, malignant lesion, which we should bother about in a cirrhotic patient, right? See, actually I cannot move cursor. The upper row and the lower row. Upper row image is the non-contrast image. First is the, sir, can you see the both row images?
Yes, 2 rows.
So it is non-contrast scan. First is T2 weighted image, where you could see there is a bright lesion inside liver. On T1 weighted image, it is darker than the rest of the liver. There is usual characteristic of a hepatocellular carcinoma. It will be diffusion restricted. The lower row images are the contrast image. First two images, the early and late arterial phase image, where you could see the lesion stand apart. It is brighter than the rest of the liver. And the portal venous phase image showing the washout of that, means it is become darker than the rest of the liver. However, there is a well-defined peripheral capsule. So all characteristics of a hepatocellular carcinoma is fitting. Both the enhancement pattern, like arterial phase hyper-enhancing, washout on portal venous phase, capsule is there, size is more than 1 centimeter, and on T2 weighted image, it is hyperdense, that means brighter. On diffusion weighted image, it is restricted. In phase, opposed phase would be, if you do a in phase and opposed phase image, you will see there will be signal drop because of the fat. So these all are characteristic features of hepatocellular carcinoma we should see and characterize when we do a triple phase MRI of a liver to figure out the lesion or to characterize the lesion in a cirrhotic liver. Similarly, this is another case showing a lesion. I'm sure you can appreciate the lesion. Upper three sections. First is the T2 weighted image. It is a peripherally situated lesion showing irregular peripheral margin. You see the traction of the overlying capsule of liver, suggesting a fibrotic nature of the lesion. And if you see the diffusion weighted image, second picture, upper row, it is peripheral diffusion restriction. It is typical of rim-like diffusion restriction. Centrally, it's not diffusion restricted, peripherally restricted. The enhancement is also rim-like enhancement. Washout is again rim-like washout. And if you see the delayed images, you see the central filling in or delayed central contrast enhancement. So this is telltale feature of intrahepatic cholangiocarcinoma. If you see this type of picture, peripheral rim enhancement, peripheral washout, and delayed central enhancement with a capsular retraction because of its fibrotic nature. So we are 100% sure this is, we categorize it in LRM. LRM means definitely malignant, but not fitting with the ACC. This is most likely intrahepatic cholangiocarcinoma. I think, sir, I am going into more of a radiology discussion. I think them it will be a bit difficult. I think now I'd like to answer the questions they want to ask me. I can see only Mohul, and so I am asking him only. Do you have any query?
There are people there. Dr. Pushenjit, Dr. Diptaman, Anirban, Dr. Sujan.
So anyone having any question? Or I need to clarify some part of my talk?
Just ask. If you see a cystic lesion, to say simple cyst or hydrated cyst, what are the specific things you'd like to look for?
Well, so as I said, if it is a hydrated cyst which is CL stage, it is a clear cyst, there is imperceptible wall, then really it is very difficult to differentiate a simple cyst versus hydrated cyst. Many of the time we send IgM for hydrated echinococcus and all these things. Most of the time the report becomes negative. Then we are back to square one. A simple cyst versus a CL stage of hydrated cyst is very difficult to differentiate. If we see a dependent hydrated sand or dependent debris, it will favor the hydrated etiology. Otherwise, and the other stages of hepatic disease, hepatic hydrated cyst, would have a different characteristic features. Like in CE1, it would have a well-defined wall, hydrated sand, dependent debris. In CE2, it would have a internal multiple cystic lesions inside a daughter cyst. In CE3, there will be a detachable or detached curvilinear membrane, echogenic membrane inside. CE4, it will be an inhomogeneous or heterogeneous soft tissue mass-like structure. There is no cyst, almost there is no cyst inside. And in CE5, there will be peripheral rim-like calcification. So this C4 and 5 is a dead type or inactive variety. C3 is transient, is a transition between the active and inactive stage. Cl, CE1 and CE2 are the active stages of hepatic cyst, hepatic hydatidic cyst.
One question.
Hello.
Yes.
Hello. I am Dr. Basak. I work in KPC Medical College. I have got a question. You have described the pictures very clearly and nicely, so nobody is asking you a question. But if you find a lesion which is probably malignant and C4, then how to proceed? Like that 4.
All right.
Because benign it is fine, malignant it is fine, and you can treat these lesions by embolization or other radiological procedures or needle and things. But when it comes to probably malignant in a cirrhotic liver, then how you will approach?
Correct, sir. So first of all, yeah, is a very pertinent question because
It's a nice discussion.
yes,
Nice discussion.
we face it
Okay.
very frequently that the lesion is not fitting with LR5 lesion. That means it's not definite HCC, but it's probably HCC. LR4 means probably HCC. We
Yes.
anyway we send the blood markers for tumors like alpha fetoprotein CA 19.9. We send for to differentiate between ICC and HCC. But the consensus said if a lesion is having a arterial phase enhancement, even if it is not having washout, if it is having arterial phase enhancement and size is more than 2 centimeter, so most likely we are dealing with an HCC. LR4 means is probably HCC, and if the alpha fetoprotein is raised, then is our job is done. We straight away go for LR4 lesion. Like it depends on the size again. If it is surgically, we can resect it or we can plan for transplant is fine. Otherwise, the smaller lesion LR4 we can directly go for radio frequency ablation, because sir, if it is a less than 3 centimeter lesion, hitting the lesion, few of the patients would have ascites and the liver would be definitely significantly fibrosed. F4 fibrosis would be there. There will be chance of hemoperitoneum if I go for a biopsy. So if the lesion is LR4 and alpha fetoprotein is borderline high or raised, then we do not try to prove. But personally, like the literature from radiology aspects, we do not try to prove the lesion taking a biopsy. We directly go in and hit the lesion and burn it from our side. Like we do RFA if it is smaller
And
lesion.
I've got another question. Could this type of lesion be a solitary hepatic metastasis? So how do you differentiate between solitary hepatic metastasis in a cirrhotic patient and this?
All right, sir. So basically, the solitary hepatic metastasis, if it is a hypervascular metastasis in a cirrhotic liver, I told in previous slides that that is the area where we would be calling it probably LRM. And sometimes in a cirrhotic patient may have a known primary, may not have a known primary. There may be a lesion in liver which is hyper enhancing. But in that particular case, we would be seeing the other characteristic features like the washout on portal venous phase, peripheral ream, that ream which we see in a bit delayed phases of contrast study. So, and this in-phase, opposite phase scan would tell us whether this lesion contains any fat molecule inside or not. They all characteristic would not fit with a solitary hypervascular metastasis. But still, again, as you said, if it is a LRM, and it's not fitting with the picture of IACC also, it's not intrahepatic cholangiocarcinoma, and as liver is cirrhotic, then we would probably think it is a HCC. Sir, in that particular case, I think we have done biopsies also. If we are stuck in that way, if we don't have the known primary, and this picture is not fitting with HCC also, probably patient may have, or patient probably is having a smaller lesion in lung. We cannot biopsy that because it is a perihilar lesion and there is a lesion in cirrhotic liver which is hyper enhancing. Then we have to hit that liver lesion and figure it out.
But it is said that in case of primary hepatocellular carcinoma, we should avoid biopsy.
Always. we should always biopsy.
So there is a saying that we should not do biopsy if you suggest this is a primary hepatocellular carcinoma or cholangiocarcinoma, isn't it?
True. So that's why you made this picture a bit complicated. No, that's why I'm saying. Had it been
No, no.
F4 lesion and raised alpha fetoprotein level, we would not do biopsy. We straight away go for either resection or ablation. However, if suppose the patient is having a solid a lesion in lung, or a patient CA 19.9 level is high, a solitary hypervascular liver lesion in a cirrhotic liver, which is not fitting exactly the enhancement characteristic of the HCC. Alpha fetoprotein is not raised, the other tumor marker is raised. Then we are now, because see, we RFA if it is solitary metastasis, if it is a colorectal metastasis, we can try for this RFA. Otherwise, it will not be helpful. So we need to diagnose the lesion. If we are stuck with that, because if the other parameters like MR is not contributing, the other pictures are not contributing, it's probably malignant, most likely malignant lesion, but probably not HCC. In that very few number of cases, we can do a biopsy, but mostly we don't do it.
Thank you.
Thank you, sir.
Thank you.
Usually in LR4 or LR5, we don't do biopsy. Even for LRM also, if it is very clear cut for a intrahepatic cholangiocarcinoma, we don't do biopsy most of the time. But LR3 lesions, and as I said, few lesions where solitary hypervascular metastasis we're suspecting is not fitting with anything else, then we have to go in and hit the lesion.
One PG asked, what are the indications for doing a diffusion weighted imaging? When you do diffusion weighted imaging,
diffusion weighted image, a diffusion sequence is a fabulous sequence. It is it takes 40 seconds, so it is not time consuming, and it gives us so many important informations that even in brain it is a standard sequence taken in every patient in brain. Even in abdomen also, we take diffusion wherever we actually, it is also a standard sequence for abdomen also. In a setting of acute pancreatitis, to deal with the peripancreatic or peripleural lymph nodes, whether those lymph nodes are reactive or mitotic, whether neuroendocrine tumor, or it is a focal intrapancreatic pseudocyst or some other lesion in pancreas, to characterize the different types of liver lesions. So in all areas, diffusion plays a huge role. Diffusion, even in MRCP also, in all MRCP patients, we take a diffusion weighted image. Yeah. Diffusion, because of like all the lesions or all the suppose lymph nodes having infiltration inside, they will be hypercellular. And if the lymph nodes or a lesion is hypercellular, it will be bright on diffusion weighted image. So it is a very.
That means there is diffusion restriction. That means there is diffusion restriction.
Diffusion restriction. We always do diffusion and ADC sequence hand in hand. And ADC, the lesion would be, the lesion which is bright on diffusion would be black on ADC. And we can actually measure the value of ADC and characterize the different lesions.
Suppose they are given a X-ray plate in the examination, suppose a CT plate. Mm-hmm. So how they could describe a particular lesion? Suppose one lesion you have shown in the background of cirrhosis. So what should be a classic description? How they should describe a classic lesion in the liver?
Sir, on plates, actually, first of all, they need to understand the different phases of on CT scan. They need to understand the different phases of study. In plates, it will be written that this is non-contrast study, this is arterial phase study, this is portal venous phase, or this is delayed phase. And on MRI, if they are provided with MRI, they need to understand the basic sequences. They need to see and tell, okay, this is T2 weighted image, this is T1 weighted, this is diffusion, this is post-contrast, arterial, portal venous, or delayed image. If they can do so, the half job is done. So they can characterize the lesion like this. This is a liver showing a heterogeneous parenchymal attenuation or intensity, heterogeneous signal intensity, depending on whether they are reporting CT scan or MRI. showing a nodular outline and relative enlargement of left and caudate lobes. So probably we are dealing with a cirrhotic liver. And in that liver, there is a lesion in either right lobe or left lobe, showing these and these characters. They may be hyperintense on T2-weighted image, showing diffusion restriction. On contrast study, it shows a non-rim enhancement on arterial phase of contrast study, and on portal venous phase, it shows washout. On delayed images, it shows a peripheral hyperenhancing rim. So if you tell all these things, if the lesion is more than 1 centimeter, so automatically this lesion falls into the category of LR5. If it is LR5, then if you go through the Lyra's classification, they are saying if the lesion is more than 1 centimeter, if the lesion shows arterial phase hyperenhancement, if these two pictures are there, then one of any three, like either washout or peripheral capsule or the threshold growth, any of these three, if it is there, then it is LR5. We can stamp it HCC, definite HCC, and start treating it. We need not to go for any other test, any other investigations.
Yes. Thank you, Dr. Bhattacharya. 9 o'clock. Thank you very much. So it's a good introduction to the resident for interpreting some of these imaging findings. We'll have some more class. I'll let you know. Thank you. Thank you very much. Thank you.